Hello, my name is Justin Yurong, and I'm the EMS Training Coordinator for Yakima County Department of EMS. I'm a nationally registered paramedic, and I've been involved in EMS for about 10 years now. I hold a Bachelor's of Science degree from Eastern Kentucky University and currently completing my Master's of Science in Emergency Health Services with a concentration in Emergency Health Services education. During my career, I worked primarily as a 911 paramedic with some experience in critical care transport and as a dispatcher. I've taught at all levels from EMT through paramedic, and I most recently came to this job from the Kingdom of Saudi Arabia, where I helped set up one of the first bachelor degree paramedic programs. I've been with Yakima County EMS since January of 2013. Today we're going to talk about CPR choreography, or how we can use a team-based approach to enhance our cardiac arrest survivability. Let's take a look at what a normal cardiac arrest looks like.
What's with this guy? Pulse there. Right there.
Don't see any medical alert necklaces or bracelets.
Go ahead and start CPR. 1, 2, 3, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18,
Applying pads to patient's bare chest.
5, 36, 37,
Plug in
38,
pads
39,
connector
4.
next to flashing light.
This is Brian Paul, Advanced EMT with Nile Rescue 10 on scene of a 45-year-old male found down unconscious, not breathing, unresponsive.
Plug in connector.
No medical alert necklaces or bracelets are seen. No bystanders at the scene.
Analyzing heart.
Unknown type medical condition, if any.
Touch the patient.
CPR is in progress.
Shock advised. Charging.
Okay, continue
Stay
CPR.
clear of patient. Deliver shock now.
I'm clear, you're clear, we're all clear.
Shock delivered.
First shock delivered at 1935 hours.
Begin CPR.
No signs of breathing, apneic,
4, 5, 6,
cyanotic, CPR in progress.
12, 13, 14, 15, 16, 17, 18, 20, 21, 22, 23, 25, 26, 27, 28, 29, 30. 1, 2, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Patient appears to live on his own.
17, 18.
House is reasonably well kept. No sign of drug paraphernalia.
25, 26, 28, 29, 30. 1, 2, 1, 2, 3, 4, 5, 7, 8, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 25, 26, 27, 28, 30. 1, 2, 1, 2, 3, 4, 5, 7, 8, 10.
Patient's skin color still appears to be poor. Patient is still apneic.
17, 18, 19, 20.
Okay, get ready to switch.
24, 25, 26, 28, 29, 30. 1, 2.
Okay, switch. I'm going to step into the ventilator role.
26, 27, 28, 29, 30. Twenty-seven, 28, 29, 30. 1.
Stop CPR. Analyzing heart rhythm. Stay clear of patient.
We're all clear of patient.
Shock advised.
Check pad. Right side.
Deliver shock now. Press the
I'm
shock
clear, we're all
delivered.
clear.
Shock
Pause.
delivered.
Begin CPR.
At 1937 hours.
Excuse me.
Okay, we are still getting good ventilations, good chest rise, chest fall. Go ahead and place the device.
12, 13, 14, 16, 17, 18, 19, 20, 22, 23, 24, 25, 26, 27,
Hey guys, what's going on?
29, 30.
We have a 45-year-old male who was found down and unconscious, unknown type medical aid. Patient has no known drug allergies that we know of. No medical alert necklaces or bracelets were found at the scene. Patient appears to live alone. He's had 2 shocks on board, one at 19:30 and one at 19:35 hours. CPR has been in progress now for approximately 7 minutes.
Okay. I'll tell you what, then, when you're next on your next analyze, I'm going to change out my monitor on here. We'll get your stuff
Okay.
out of the way.
Stop CPR. Analyzing heart rhythm.
Go ahead
Stay
and
clear
turn your
of
AED off
patient.
for me. Just turn it right off.
Shock it.
Okay. Probably just chest compressions. Do some chest compressions for me.
Tell me if you want me to take over.
After this one.
Okay.
Okay.
23,
Go ahead and hold chest compressions. Looks like we're in V-fib. Go ahead and charge this up. Everybody clear off the patient?
Clear.
I'm clear, you're clear, everybody's clear. Okay, go ahead and start doing the chest compressions again for me. Brian, if you don't mind, an IV put it over there for me.
Roger that. You take over ventilations, please.
Sir. Is that king your way in there good?
We have good establishment and we've had good chest rise, chest fall.
Okay.
10 seconds, just go ahead and do it. 10 seconds.
You ready?
I just keep going.
I guess we'll leave the king for now.
Okay.
How long is that been? It's been about 2 minutes, right? Okay, let's go ahead and stop chest compressions. Looks like it's still V-fib. Get it charged up here. Yeah, y'all can switch out. And clear, I'm clear, you're clear, we're all
Clear.
After watching the video, we might think that they did a pretty good job. However, the purpose of this OTEP module is to move us from a good job to an excellent job. So what do you as a BLS provider need to take away from this OTEP training? You own CPR. In Yakima County, the EMT or at the BLS level, you are responsible for making sure that consistent, high-quality CPR is going on all of the time. We want to eliminate every possible second of hands-off time during these cardiac arrests. And that's what this training is really about. It's going to be eliminating mere seconds from our hands-off time during cardiac arrests. So why do we need to do this training? Simply put, it's because we want to save more lives. Let's take a quick look at the science behind why these good chest compressions and why having good CPR is so important. So it's not news to probably any of you. When we compress on the chest, we are ejecting blood out of the heart and sending it to the brain. When we do a complete chest recoil, we are decreasing the interthoracic pressure and refueling the heart. So when we have this good recoil, we're sucking enough blood back into the heart to supply the heart with blood and then to have it ready to pump out again. When we do a chest compression, we are creating pressure, which is sending blood to the brain. We're trying to increase what we call the coronary perfusion pressure, or the amount of pressure it takes to move blood all the way up to the brain. And through research, they've determined that a coronary perfusion pressure of at least 15 millimeters of mercury is what's required to give the brain enough oxygen to survive. The higher that number goes, the better chance of survival that we have. What we're seeing here is a chart of the pressure in our aorta versus chest compressions. If you look at this, we see we have 3 seconds pauses in between before the chest compression started and after the chest compressions ended. As we do our chest compression, it takes almost 8 seconds worth of chest compressions in order to build our pressure up high enough to where we're sending blood to the brain. So just by stopping CPR for 3 seconds, we're going to waste half of our next 30 compression cycle just building up enough pressure to give that brain survivability. Let's take a look at the math of CPR. What we're seeing here in this chart is a cycle of 30 to 2 chest compressions with your pink line there in the middle representing your pressure, the actual pressure that the chest compressions is generating. So on the middle of our chart here, we're seeing that if you do things absolutely picture perfect, we're doing 150 compressions in 2 minutes, that's giving us an average compression rate of about 75 per minute. Remember, AHA recommends that we have a compression rate of at least 100 per minute. Our CPR fraction time is going to be 75%. So 75% of the time doing picture perfect CPR, we're actually having hands on the chest. Now, looking down below that, we're seeing this real world example. So in the real world, we're wasting a second here or there doing different things. And that's bringing our CPR fraction down to about 69%. And again, this is doing really good, high quality CPR. On this next chart here, we're seeing someone doing continuous chest compressions. So this would be like you have your king airway that's been inserted. Once the king airway has been inserted, we could do that consistent chest compressions. And doing perfect chest compressions like this, we're looking at a CPR fraction of 100%. So we're going and we're doing our chest compressions 100% of the time we're going to be on the chest, except when we add that shock in there. And for this one, this particular model of AED takes about 7 seconds to analyze and shock. That is giving us a CPR fraction of about 94%. So that's what we're really going for, eliminating every little second. Every second we don't do compressions during, it's lowering that CPR fraction time and dropping the pressure of blood to the brain. So this is more of a standard looking CPR. This here is they're planning on doing 30 to 2, so you can see we start out with 30 chest compressions, and then we give our 2 breaths, and then we have an unexpected pause. This pause might be anything from the chest compression person had to stop to help with the AED, they stopped to put the AED on, maybe they stopped to put a king airway in. So we were stopping there, our compression rate is going all the way down to 0. Including the AED, our fraction rate over this CPR here is only 55%. This is why it's so important for the chest compression person to be focusing on nothing but doing those chest compressions, not stopping for anything, except if the ALS person on scene happens to ask you to stop for a particular reason. Looking at the results from the video we just watched, we can see that we did not do chest compressions for 2 minutes and 17 seconds out of the 7-minute and 39-second arrest. This means we were only doing chest compressions about 70% of the time. While this result isn't terrible, through education and training, we can greatly increase these results. Let's take a look at why doing great, high-quality CPR is so important. This first study looks at the effect of incomplete chest wall recoil during CPR. This is when we're doing CPR and not completely releasing from the compression, not coming all the way back up off the chest. If you remember from Module 6, our CPR module from 2013, you'll remember we did training with this by using our high-performance CPR mannequins. So what they did with this study is they took some swine, some pigs, and they put them in VFib for 6 minutes. They then did good quality CPR for 3 minutes, followed by 1 minute of CPR that was not good. We had 75% chest wall recoil. So we're leaning on that chest and not letting our hands come all the way back up. We followed that up by 1 minute of good CPR, and then we defibrillated them 3 times and went on to advanced life support procedures. And what we saw from this is that when we're doing our good chest wall recoil, we're getting plenty of coronary perfusion pressure. It's about 23 on this chart. Remember, we only need 15 in order to get ROSC. When we went down to our poor chest compressions, we barely hit that 15 mark. And so that decreases the patient's chance of survivability significantly. Now, the shocking thing here is when we went back up to full good chest compressions, we never did get our numbers all the way back up there. It only got up to about 16 or 17. So what this is showing us is by doing poor chest compressions for only 1 minute, we're decreasing our overall outcome of the cardiac arrest. Because we do poor chest compressions for 1 minute, we're never able to get back to that same level. So how can we improve this hands-off time, and how can we improve our overall effectiveness when we're working cardiac arrests? We want to follow a very carefully choreographed routine when we're on that cardiac arrest. We do this by having clearly defined roles. Everyone who's in that room working their rest should know exactly what they're supposed to be doing. Once they know their jobs, they need to perform their jobs flawlessly. They need to practice and practice and practice until they know exactly what they're doing and exactly what everyone else around them is doing, what's expected of them. What are our performance goals? Overall, we want to see consistent, high-quality compressions during the entire cardiac arrest. We want to eliminate every single second of unnecessary hands-off time that we possibly can, and we want to use this team-based approach in order to help facilitate this. Something to note before we go any further is that there's no perfect recipe for choreographing CPR in Yakima County. We all come from vastly different departments, different backgrounds. We have different staffing levels and different resources. So every individual agency is going to have to figure out how the CPR or the cardiac arrest choreography is going to work for them. We're going to give you some hints and some tips, and we're also going to provide you some experiences of other departments who have put this kind of training into effect. At a minimum, though, the plan should always allow for high-quality chest compressions with minimal interruptions. That's the big thing, which is going to bring us to rule number 1. Nothing is more important than high-quality CPR. Absolutely nothing we can do, no ALS intervention, no defibrillation, no airway maneuver is more important than doing high-quality CPR. And along with this rule, we'll call Rule 1A, is saying that EMTs own CPR. You as BLS providers are going to be responsible for making sure that consistent, high-quality CPR is taking place during the entire time that patient is in cardiac arrest, even after ALS arrives. Once ALS arrives, yes, they're responsible for that patient care, but you're responsible to make sure that high-quality CPR is going on the entire time. Brings us to rule number 2. You need to know your role and play it very well. We're going to switch over and hear from Norm Nadell with Seattle Fire Department on how they developed their approach to cardiac arrest resuscitation.
So my name's Norm Nadell. I'm a Seattle Fire Department firefighter, senior paramedic, dispatcher. One of the other hats I wear is I work for University of Washington paramedic training as well.
How did you get started with this concept of high-performance CPR?
So it really started pretty informally. About 6 or 8 years ago, our EMS training lieutenant at the time was Jonathan Larson. He's now captain, but at the time he was our EMS training coordinator, and we really started looking at our survival rates. We really started looking at the way we ran resuscitations. And a lot of this sort of happened by accident. Jonathan started looking at CPR fraction times, or in other words, how long were the hands actually on the chest. And we go back as far as when we were still doing 15 compressions and 2 ventilations before we went to 30 to 2. And he really just started taking things apart, and what we realized is that we really only had our hands on the chest about 70% of the time, and in some cases less. And that's really how it started. And we thought, well, maybe if we take a look at how we're doing things, how we actually choreograph our resuscitations, maybe we can improve a little bit.
What roles do you consider to be critical when working at cardiac arrest?
A great question, and something that we still are working on trying to formalize. You've got to have a timekeeper, and if you've only got 2 people that show up, you've got to designate who's going to keep time, and it probably can't be the person, obviously, that starts out with compressions. So you're going to have to, before you hit the door, designate who's going to be that compression person. So if you have a 3-person crew, or even a 2-person crew, when you designate it, I don't know. We've talked about different methods. Some of our crews designate it at roll call in the morning. Now, if you're a volunteer agency or part-paid agency responding from other places, that's not going to be so easy. But clearly, you've got to have a timekeeper, and you've got to have a chest compression person. In a 2-person team, the single most important thing is going to be that chest compression person. So as they come through the door, we use the CAB approach, And I like to say, and I've said it publicly and I've said it nationally, and people look at me and go, well, that's kind of brutal. But the reality of it is, if you see a patient and they look dead, they are dead. So wasting a lot of time cutting off clothes, checking pulses for more than 10 seconds, it's just wasting time. So in our two-person approach, we designate a chest compression person. The second person's going to apply the AED, and we're going to leave the airway alone for that first rotation of chest compressions. So it may be as long as 2 minutes, depending on how long it takes that second person to apply the AED. So the first person through the door will be a chest compression person. The second person will be the AED person. The third person coming in ends up being our airway person.
So here in Yakima County, what are the minimum roles that should be filled during a cardiac arrest at the BLS level? And these are the 4 areas that we've identified. Now remember, you might not have 4 people on scene for that cardiac arrest, especially in the first few minutes. So one person might have to fill more than one role. Here's an example of how I could see things working. If we have a 2-man crew that initially gets there, we have responder number 1, chest compressions. That's their only job, is making sure those chest compressions are getting done. Responder number 2 fills timekeeper, team leader, and the AED operator role. If we have a 3-man crew, we can divvy out the work even more. We have 1 responder doing chest compressions, another running the AED and being the team leader, and a third working on the airway. So let's break down each one of these roles and see what their responsibilities are. Now, it'd be essential that you learn each one of these roles and you understand what that role is, because during the cardiac arrest, chances are you're going to have to switch roles, especially when it comes out to changing out chest compressions. So the chest compressor. This is the most important job on the entire team. Their role is to do chest compressions, and that is their only role. Once they start chest compressions, the only thing that they should be doing is those chest compressions. He or she should be the first one through the door, and when he walks in, he looks at the patient. If the patient looks dead, looks like they're not breathing, they should immediately check a pulse. After no more than 10 seconds, if they're not feeling a pulse, CPR should be started immediately. Once they start CPR, they should zone out and focus only on those chest compressions and not worry about anything else going on around them. Let other people take care of their jobs. Always, 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 as the chest compressor, remember, you do not want to interrupt those chest compressions for any more than 3 seconds. Keep those interruptions down to a bare minimum. From the chest compressor, we're looking for chest compressions that must be at least 2 inches deep and allow the chest to fully recoil with every single chest compression. The rate should be at least 100 compressions per minute, but should be no more than 120 compressions per minute. Once an advanced airway has been placed, or the King airway in Yakima County, then you will do continuous chest compressions and not stop unless the AED tells you to stop or an ALS provider tells you to stop. Talking about switching chest compressors is a very important topic. Chest compressors should, must, and will change every 2 minutes. This is mandatory even if it's going to delay you doing something else. So if we're at the 2-minute mark, chest compressors must change. Even if this is going to delay you putting in a King airway, backboarding the patient, putting the AED on, it doesn't matter. Nothing is more important than those high quality chest compressions, and we found that doing chest compressions longer than 2 minutes decreases their effectiveness. There is no macho man or woman who's going to be an exception to this rule. And a simple fact that if you don't change chest compression, this is probably what's going to happen.
Ain't nobody got time for that.
2 of the most common mistakes that we see with chest compressions here in Yakima County are not allowing the chest to completely recoil and compressing too fast. Once we get into the heat of a cardiac arrest, we tend to compress at a rate of about 130 per minute. We want that to be between 100 and 120. So, practicing consistently and getting that rhythm down is very important. The next role we're going to discuss is that of the team leader. It's the team leader's job to make sure that everyone else's job is being done correctly and to communicate the next step in the process. Depending on how many people you have on scene, this is an excellent person who will also keep track of all the times. The time the cardiac arrest started, the time your first chest compressions were administered, the time of each AED shock. It's really important for this information, not only for research, but also when ALS arrives, they're going to need to know what's been done so far. As the team leader, you want to stand back if at all possible so you can see everyone else doing their job. It's essential that you're making sure that that chest compressor is switching out every 2 minutes. You can also take on other roles that does not interfere with good chest compressions, such as getting equipment or talking to the family. The AED person is responsible for applying the AED and running that AED during the cardiac arrest. Now again, these roles can switch. The person who was at chest compressions could be moving to AED. The AED person could be moving to airway. It's going to be up to you and your department to figure out the best system for you. The person working the AED always applies that AED without interrupting chest compressions. We never interrupt chest compressions just to put an AED on. If this was a witnessed arrest, or if they have been in cardiac arrest for 4 minutes or less, they will immediately turn on and apply the AED. If it is an unwitnessed arrest, then they will apply the AED and turn it on, but do not plug in the pads until 2 minutes of high quality CPR has been performed. Once we plug in those pads, the AED is going to begin analyzing. We don't want the AED to analyze until we have done 2 minutes of high quality CPR to get that heart ready for a defibrillation. Speaking of the AED, let's talk about doing chest compressions while the AED is charging. In 2013, we recommended that you do chest compressions while the AED is charging. And this is still what we'd like to happen, but after doing an exhaustive review of all the AEDs in the county, there's only 2 models that actually support chest compressions during AED charging. So if your AED doesn't look like what's on the screen now, you must stop chest compressions while the AED is analyzing and charging. You cannot begin chest compressions again until after the AED delivers the shock. However, once an ALS unit arrives on scene, do chest compressions until they tell you to halt. The final job we're going to talk about is the airway person. The airway person is actually the least important role on the cardiac arrest team during those initial stages. If messing with the airway is going to affect chest compressions, then we simply won't do it. The airway person will perform all the airway maneuvers, such as BVM ventilations, putting in airway adjuncts, the nasal airways or oropharyngeal airways, and inserting the King airway. They can do these roles as long as chest compressions are not being interrupted. Remember, if the patient does not have an advanced airway in, then we need to do a ratio of 30:2. If they do have an advanced airway or that King, then we can do consistent CPR. It's important that there's communication between the chest compressor and the airway person so we minimize the delay between stopping compressions and starting the next ventilation. The average adult patient only needs 400 to 700 cc's of air. So if you have a really good mask seal or you have an advanced airway in, we're only going to squeeze that BVM 1/3 to 1/2 of its total volume, just enough to see the chest rise. Putting too much air into the patient, number 1, can cause gastric distension, which means you'll be wearing your patient's last meal. Number 2, it can actually increase the interthoracic pressure, which will decrease our CPR effectiveness. Rule number 3 of the CPR choreography is to keep hands-off times to a bare minimum. So what things cause us to be off the chest? We've got an example of things on your screen right now. Things like the time it takes between stopping chest compressions and doing ventilations when we don't have an advanced airway in. Sometimes people will stop chest compressions to apply the AED or the cardiac monitor, putting advanced airways, putting IVs in, checking pulses, backboarding. What's really important is to realize that most of these things can be avoided. So what is skill mastery? Skill mastery is knowing your job and doing it well. So if we're putting a King airway, we should know exactly the steps to insert that King airway as to not waste any time. Same thing goes with putting in IVs or attaching the AED or monitor. We should know exactly how to do these skills ahead of time so there's no hesitation while we're doing it. Remember, 1 or 2 seconds is huge when it comes to our patient's outcome. Remember, the chest compressor, his only job, his only skill he needs to do is to push hard on that chest and make sure it's coming completely recoiling at a rate of between 100 and 120 per minute. He shouldn't help anybody do anything else. Effective communication and staying ahead of the curve. What we're talking about here is letting people know what's going to happen before it happens. So if I'm the chest compressor, I should be counting my chest compressions out loud. That way the ventilation person or the airway person knows exactly when they're going to be giving their breaths. So we'll take off a second here or there just by that. The time switching compressors. We switch our chest compressors every 2 minutes. What's great with this is we should switch chest compressors every time that AED says analyze. That way, the AED is automatically doing our timing, and it gives us a few seconds to switch chest compressors where we can't be touching the patient anyways. This goes hand in hand with effective leadership. Whether that leader is the BLS person that's on scene or after ALS arrives, the medic arriving. Having effective leadership means that we are thinking ahead of the game and that we know exactly what the next step is and communicating that next step to everyone else. Once ALS arrives on scene, that lead paramedic is now in charge. However, they will not forget rule number 1. Rule number 1 is that nothing interferes with high quality chest compressions, and rule number 1A is that EMTs own CPR. Once they arrive, they are going to expect you to continue doing perfect, high-quality CPR while they worry about all the advanced life support things that they need to get done. So we're going ahead and repeat a previous rule because it's so important and call it rule number 4. Nothing is more important than high-performance CPR. Putting your king airway in is not as important as high-performance CPR. Backboarding the patients, putting an IV in, any medication, anything that advanced life support is going to do, none of those things is more important than having good, high-quality CPR happening during the entire arrest. Remember that timing is going to be everything. Just like when we're doing a dance, your timing has to be right. When we're doing the CPR choreography, our timing must be great also. You should time your intervention so there's no interruption of CPR. So if I'm going to put an advanced airway in, let's put that advanced airway in while we're in the middle of a set of compressions. Rule number 5, if you're stopping chest compressions during a cardiac arrest, you're probably doing something wrong. There are a few exceptions to this that we'll speak about in a moment. So let's take a moment to see what a cardiac arrest should look like when the responders are using an excellent, cohesive, team-based approach.
Sir, can you hear me? And no pulse. Starting CPR.
Here's apnea.
Apply pads to patient's clear chest. Plug in pads connector next to flashing light.
15 liters.
10 liters.
Apply pads. Plug in connector.
Four, 55, 56, 57, 58, 59, 60.
Apply pads. Plug
Good
in
chest rise.
1, 2, 4, 5, 7, 9, 10, 60.
Apply pads.
21.
Insert connector firmly.
25, 26, 27, 29, 30.
First set complete. Getting good chest rise and chest fall.
Insert connector firmly.
19, 20, 21, 23, 24, 25,
Okay.
27, 28, 29, 30.
Apply pads.
Fourth set complete.
Insert connector firmly.
1, 2, 3, go ahead.
Okay, here it goes, starting analyzing now. Keep going, keep going.
Analyzing heart
Clear.
rhythm.
Clear.
Clear.
Do
Switch.
not touch the patient.
Clear.
Shock advised.
Clear.
Stay
Charging.
clear.
Stay clear of patient.
Okay, as soon as I get
Deliver
the
All
shock.
clear.
Shock delivered.
Okay.
Pause.
First shock delivered at 2025.
CPR.
7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Continuous.
Stop CPR.
Stopping CPR.
Analyzing heart rhythm.
Give me a breath.
Stay clear of patient.
Another breath.
Shock advised.
Good. Stand clear.
Okay, clear.
Deliver shock now. Press the orange button. Shock
So
delivered.
shock delivered at 20:29.
Begin CPR.
Patient is still apneic, not breathing.
Hey guys, when's the last time you gave a shock?
2028, about 1 minute ago.
Okay, why don't you go ahead and get an IV for me, Sergeant Brian? You guys keeping your high performance
Roger that.
CPR?
That was actually 2029.
Everyone ready, sir? Keep doing what you're doing. Good, solid compressions. How's that cane feeling over there?
Good.
You have good breath sounds on it?
Good breath sound when you cut.
Keep doing your chest compressions for me. What's going to happen, guys, is when I come up to my cycle, I am going to, when I come up to the cycle, I'm going to go ahead and charge up my monitor.
Okay.
When I get ready to charge the monitor, you guys are going to do your switch. So whoever's in the airway, I want you to come over to do chest compressions.
Okay.
It's going to be a really quick switch here, okay?
Ready?
Looks like we got about 30 seconds out.
Come on.
Continue compressions, I'm charging. We got an electrode off somewhere here. Okay, I'm charging, continue with electrodes. Go ahead and switch compressors, clear the patient, unclear, we're in V-fib.
Clear.
And continue compressions, please. Continue compressions. Okay, we've got 2 minutes. I got 2035 on my monitor. We're going to 2037. We got an IV coming up over that way.
Stop
Roger that.
CPR.
Go ahead and turn off your AED for me. Thank
Off.
you. Yes, turn that AED off.
Yes.
So give me the total breakdown. What happened here?
We had approximately 45-year-old male unconscious on arrival to the residence. Patient appears to live alone. We didn't see any medical alert necklaces or bracelets on the patient, so it's unknown if he has any type of medical history. Patient was apneic and cyanotic on arrival. He was also diaphoretic. CPR was begun immediately.
Do we have an idea how long he was down before you guys got here?
That's unknown. Call came in at 2020. We arrived at 2025. So we're assuming possibly 5 minutes, but it could have been longer.
And did you have any kind of no shocks, or are they all shocks?
They were all shocks.
Okay.
First shock was at 2024, and the last shock was at 2029.
Okay, we're 1 minute into the CPR, so in about 30 more seconds, I'm going to charge our monitor up. We're going to switch compressors again. Airway, you're going to come over to the chest compression side. Same drill as last time.
Going with an 18 gauge in the right AC.
Okay, looks like we got IV access in there. Okay, we got about 20 seconds left. I'm charging up. Continue CPR. And we're charged to 200. We're going to be switching out in 10 seconds. I'll do a rhythm check. Rhythm check in 5 seconds.
I'll go behind you.
Okay, everyone hands off. Clear the patient.
Clear.
I'm looking at V-fib, shocking. Continue chest compressions, please. We have IV access in. Go ahead.
IV access, 18 gauge.
Of epinephrine, 1 to 10,000.
Roger that. 1 milligram epinephrine, 1 to 10,000.
And I will be your IV pole.
Okay, thank you very much. I want to secure this IV site first.
And you are flowing just fine.
Roger.
How's that pain still feeling? Still feeling good over there?
It just feels good.
Okay. Looks like our internal CO2 is looking about 35 or so you guys are doing great there.
12, 14, 15, 16, 17, 18, 20, 21, 22, 23, 25, 26, 27, 28, 29, 30.
One milligram epi.
If we compare this latest video with our arrest from earlier, we can see that we decreased our overall hands-off time by over a minute and increased our CPR fraction time by 16%. We were able to accomplish this through simple training time with our crew. So now that we've seen what an excellent cardiac arrest should look like, let's look at when we should pause chest compressions or when we should stop CPR after it's already been started by a BLS provider. So we're going to have to stop chest compressions for the AED to analyze and shock the patient on almost every model that's in the county. If we need to move the patient or yourself away from danger, we're also going to need to stop chest compressions. If ALS asks you to pause, then again, we'll need to stop chest compressions. However, you should never do this for longer than 3 seconds. A general rule of thumb is if the ALS provider asks you to stop chest compressions, stop compressions, count to 3, and then resume chest compressions. If they need you to stop again, they're probably going to tell you. Let's look at how Seattle Fire Department handles this particular issue.
In the beginning, it was just more gentle encouragement, like, hey, that's taking a long time. Should we be back on the chest? And it evolved to now more formal process where we have a timekeeper as part of our crew, and that's a BLS person. And that person will tell the medics where they're at in the midst of that resuscitation and will tell the medics, hey, it's been 10 seconds. It's been 15 seconds. Maybe we better get you back on the chest. Now, clearly, if the medics have a procedure that they need to get done, they're ultimately in charge of the ALS end of things. But it's really a teamwork thing. It's really a collaboration.
As a BLS provider, when should you terminate resuscitation? When should we stop chest compressions and no longer attempt to resuscitate the patient? Well, the first one is the best case scenario. The patient gets ROSC. They get return of circulation, and there's no need to do chest compressions anymore. If someone happens to bring you a valid post form or a DNR order, then we would need to stop chest compressions as well. The final reason we would stop chest compressions if ALS arrives and based on their assessment, they decide that the resuscitation does not need to continue. Let's go back to Norm with Seattle Fire and hear some of the challenges they had when beginning their CPR choreography program. He'll also discuss some common mistakes that they run into that will help us avoid making those same mistakes here in Yakima County.
And the biggest challenge we had in implementing our high-performance CPR program, honestly, was not the BLS teams. It actually was the paramedics. Because medics like to think that they're in charge, and they are when it comes to ALS procedures. But what we realized is that the medics were really slowing down or keeping hands off of the chest a lot of the time. We were stopping chest compressions to start IVs. We were stopping chest compressions to intubate. We were stopping chest compressions to look at a rhythm on the screen. And so what we really did is turn the resuscitation upside down. And the biggest challenge we had actually was getting the medics to realize that, hey, chest compressions are actually more important than you starting that IV, than you securing that airway. And that if we didn't keep forward blood flow moving out of that left ventricle, no amount of drug therapy, no amount of shocking, no amount of advanced airway skills are going to save that patient. It's an aggressive approach to doing anything you can to get a pair of hands on the chest and doing it quickly. So again, if I come in and I see a patient that looks dead and I check a pulse quickly and they don't have one, I'm not going to waste time moving a bunch of or cutting a bunch of clothing right away. I might, if I had like what I'm wearing today, single shirt on, I might just put my hands in the center of the chest and start chest compressions, while the AED person works around me by starting to cut the clothing, pulling the shirt or jacket out of the way. You can apply pads while somebody's doing chest compressions. So time. We know that for every 30 seconds you delay chest compressions, there's a 5% decrease in survival. So you can do the math on that. The longer you delay, and that's for shockable rhythms, the longer you delay, the more it costs in survival. Another thing would be if you were trying to integrate this into your department and it's brand new to you, trying to do things too quickly. Work on the simple stuff. Work on basics. Work on the mechanics of chest compressions. How far are you away from the patient? What's your hand position look like? Are your elbows locked? Is your rate okay? Is your depth okay? And maybe most importantly, how's your recoil? Are you coming all the way up? Are you allowing that right ventricle to fill completely so that ultimately the left ventricle pushes blood out to the body? So if your mechanics aren't perfect as somebody new going into this, you know, that's where I would start. So I think those are probably the big challenges, just time and mechanics. But there's been plenty of agencies that have implemented high-performance CPR on a volunteer basis, on a part-paid basis, and have had significant success and significant improvement in their survival rates. And I would say start small. And I would say if you can increase survival by 5%, that's 5%. And in your system, wherever you're at, if you're only going on as a system 50 cardiac arrests in a year, well, you save one extra person, that's a huge improvement. So don't look at it as a big daunting task. Look at it as one call at a time, one patient at a time, and you will be successful. And realize that it takes somewhere, probably our experience is between 2 to 5 years to really sort of get things honed and get your crews trained and make a difference. But you'll get there. And the other thing I would say is don't give up, because it does matter. One of the things that's hard to teach anybody, and I don't believe you can teach it, is culture. So it's as Dr. Copeson has always taught us, it's a culture of excellence. So there is an expectation when the bell hits in our system and it's a cardiac arrest that that patient is going to have a better than 50-50 chance of survival. And once you have some success, it's going to spur you on to want to do a better job. Little anecdote. So we were up in Alaska doing some teaching with Dr. Kopis, and we did one of our high-performance CPR sessions for a group of volunteers from a little tiny town up there. On the way back in the ferry from the class, guy had cardiac arrest on the ferry. And this particular group had never seen a survival occur firsthand. They grabbed the AED off the boat, they implemented what they had just practiced at this little 2-hour class we put on. And by the time they got the ferry boat to the dock, the guy was awake and talking. And that spurred them on to changing the way they did business. They saw it firsthand, made a difference, and now their survival rate, even though they only have a few cardiac arrests a year, has increased. And they don't have fancy equipment, and they don't have a lot of people to respond to calls. So it works. I'm Norm Nadell with Seattle Fire, and good luck to all of you.
Thank you for participating in this OTEP module on CPR choreography and utilizing a team-based approach to cardiac arrest resuscitations. Your skill workshop for this module will include high-performance CPR and then lots of practice time on putting together a CPR choreography model that will work best for your department. Again, my name is Justin Urong with Yakima County Department EMS, and I wish you all the best.